Good morning, my name is Leslie Soden. I'm the Programme Director for the Innovation Theme at the Health Innovation Network. So welcome to our webinar on remote monitoring, keeping patients safe in the community. We'll kick off because we've got a very tight and exciting agenda. Next slide, thank you. So just a quick overview about the Health Innovation Network. So we're delivering this jointly with DigitalHealth.London Accelerator Programme. We're really excited that we've got some of the alumni and some of the existing cohort from the Accelerator Programme pitching, got 5 very exciting pitches. And that's one of our various themes that we deliver in the Health Innovation Network. We are the South London Academic Health Science Network, one of 15 working across England, funded by NHS England, NHS Improvement, and also Office for Life Science. And our aim is to support the spread and adoption of innovation. And this is a series of events that we deliver under our innovation exchange function to be able to support industry and connect them with our stakeholders in South London and across London. So just moving on, the next slide, please, Laura. So I just thought it'd be useful just to give a brief overview about the benefits of remote patient monitoring. So I came across this probably about 6 or 7 years ago. I remember being astounded that our COPD service in a community trust that I was working within West Herts, they could remotely monitor quite ill patients while they're at home and be able to monitor things like oxygen saturation rates and their heart rate, and be able to escalate when there was intervention that was needed by the COPD nurse and the team. And I was quite astounded that you could use tech in that way to be able to remotely monitor a patient, and you didn't need them in a clinic, or you didn't need to admit them into the hospital. And I was looking at this when we were talking about this workshop. There's been a lot with COVID talking about remote monitoring, and you're going to hear from Tara Donnelly later talking about the national perspective. But I was thinking about, from a patient point of view, how remote monitoring can help manage their long-term condition. And you're also going to hear from our diabetes team about what they're doing around remote monitoring as well. And there's quite a few different patient benefits that you can look at alongside the benefit to the clinician. So there's a peace of mind around improving monitoring. An example I'd give of this is, unfortunately, my sister-in-law has got coronavirus last week. She's a teaching assistant, and I knew that the oximeters would help her to be able to monitor if she needs to go and seek medical help. So I bought her one, sent it off, got some instructions, and it just gives a peace of mind for us as family members, for her mum, and also if you're looking at monitoring long-term conditions, improving the quality of life. It supports their independence, that they don't have to come in to regular appointments, they can manage their condition. And also for clinicians, there's the assurance that their clinicians know they need to be alerted if it needs to be escalated in real-time change. For a service, for a clinician, there's being able to demand within the NHS is increasing around minimising service use, about being able to use the precious clinical resource that we've got more effectively, more efficiently, be able to look and be able to risk stratify. There's also a link, and research has shown this, with a better adherence to medication, to treatment, particularly within the remote monitoring. If there's prompts around taking medicine, if there's prompts around, for example, if it's MSK, around doing their physio exercises. And then ultimately there's been research to show that it reduces emergency admissions. The COPD service that I was talking about in West Herts, they found it reduced their admissions by 30%, pretty significant. Next slide, please. So we at the Health Innovation Network, we come across, and all the HSNs, we come across lots of emerging technology. We have companies that come to us looking for advice, guidance, and being able to signpost and being able to connect them to our stakeholders in South London. And there's some really exciting emerging technology that's coming out around remote monitoring. So some of these have been around for a couple of years, but the traction's not quite there, or there's still not the evidence base. But there's one company, for example, that I've been speaking to recently that's got a biosensing wearable. So it's a watch and other kit that will be able to continuously monitor vital signs. So some of those they can do, and some of those in the future. And when I spoke to, sent off all their details to a cardiologist who's always skeptical, I always use him as a skeptic around different technology monitoring cardiovascular conditions. He was quite excited. If you can monitor blood pressure continuously, that would make a real difference to clinical care and to being able to remotely monitor some of his more complex patients. Also, there's ingestible tech, so sensors that will help with medical adherence. We were talking to a company a couple of years ago where they've been looking at, they've got a sensor that, that can be embedded into adherence to antipsychosis medicine. Or there's sensors around monitoring blood glucose levels as well, so some of that tech. And that's an emerging market as well. And then there's also the electronic skin sensors to monitor and treat muscular disorders such as Parkinson's. And then what it does, it monitors and then it releases that medication depending on what the signs are coming back to the technology. So it's a really exciting time for remote monitoring. And we're really pleased that you're going to hear from the 5 companies to talk about their tech. And we've asked them to talk through a specific topic that we've asked them to do. Can you just go to the next slide, please, Laura? So what we've asked, rather than just giving a 3-minute pitch about what their tech is, we've asked them specifically, looking at this audience, to talk about how their solution would help a clinician to monitor their patient's long-term condition. And also how would it influence, how would the tech be able to help that clinician to risk stratify their patients? And how would they be able to, how would the solution help both patient and the clinician to be able to monitor remotely? So they've got 3 minutes. And I'm going to ask the first company, SmartMed, to come on and give their 3-minute pitch.
Good morning, everyone. My name is Sadi Hussain. I'm part and co-owner of SmartMed Global. We're actually a digital health company that was established more than 5 years ago, purely focusing on long-term chronic condition management and remote care. Essentially, we've been focusing on all the chronic conditions, whether you have a single condition or multi-condition. And we have been awarded a number of awards for exports, as well as other awards that are within the digital health. Our main areas of development has been in international markets, Middle East and Far East. So that's where we are. Now, answering the 2 questions that was asked of us in terms of how we can manage long-term condition and help clinicians, and how risk stratification can be supported. Well, essentially, the way the solution works is that it's a simple app that is given to the patient, where it can be connected to a device that either can be Bluetooth device or it can be a normal device. These devices are then attached to a smartphone application where the care plans are essentially provided. When the patient goes through the various processes that the clinicians have asked for, whether to capture their blood pressure or blood glucose or any other vital signs, that is uploaded. We are also allowed to ask the patients how they're feeling, 3 or 4 questions, and that is also uploaded. The important part of the app is that it follows the care plan that you set to the patient. And also it provides other information about their condition, so they can also do self-management as well. So not always end up calling the clinicians who are extremely busy. So the important part of our solution is that it takes away a lot of the basic burden and questions away from the clinicians, and allows the patient to be empowered to follow their care plan more carefully, have reminders of their medications, and also confirmation whether the medication has been taken or not. Once that result has been taken and all those questions answered, the result is then sent back to the clinicians, and where the clinician can access this using a dashboard. Now, it doesn't have to be a single person that is accessing the information. It could be a number of different departments that can have access to that information. And also it can be set within the community as well, because our solution is cloud-based. So whether you access it within the hospital environment, the GP environment, or a community clinic, you can have access to those information. The information is then essentially given to you in a traffic light system with full details of historical data. So whether you think that the patient is getting worse over time or have breached their thresholds, the traffic light system is given to you red, amber, and green. Based on that, you can then provide the necessary support, whether it has to be an A&E support or a telephone support, or even in a simple text message or push notification support. All that is allowed through the dashboard. So you can communicate with the patient using the dashboard straight to the app. If it's a simple message to say, you're doing very well, Sadi, carry on as you are, or actually we noticed your blood oxygen level is going down a bit. Can you give us a bit more information, or call us in for an appointment, and so on. As I mentioned to you before, we have done this already in a number of areas in diabetes annual reviews, as well as management. We also done it in COPD and respiratory problems and cardiovascular. We also have patients that have multi-conditions as well, which is quite good for the clinicians to have. Thank you.
Thank you very much. Can I ask now Chris to come on to talk about Pareto? I can never say your name, sorry. The name of the company.
Hi, good morning. My name is Chris Subi. I'm a consultant in acute respiratory and critical care medicine. And we're very excited to be here today, and really pleased to be in company of people who are as passionate as we are about supporting patients with long-term conditions. A few words about Pareto. Pareto has experience for 6 years in deploying monitoring, mostly in highly complex patients, but in a number of global locations. Pareto uses a smartphone application that is linked to wearables, and those wearables can be either CE marked or consumer grade, depending on what your needs are. And the data is then fed back into a dashboard for clinicians. I'm working with Pareto on a virtual hub in North Wales, and we're currently looking after two groups of patients. One is patients who are undergoing treatment for cancer and have to shield for this, so a highly vulnerable population, and the other group is patients with COVID. So how would Pareto help clinicians to monitor their patients' long-term conditions? Can I say I'm slightly uncomfortable with the question? I think, for COVID, it's very simple. As a clinician, I can monitor what happens over a few days and maybe a couple of weeks. In long-term conditions, I can only support patients in doing what they need to do for themselves. So what we do with Pareto is we give patients symptom diaries that are linked to information in the app that allows them to adjust their self-monitoring. And then we got the wearables that give them vital signs. Again, they will have the information that they need to do what needs to be done. So we're trying to curate rather than to control. How would Pareto influence risk stratification is the third question. Well, what we're doing is we're having a triage system in our dashboard as a heat map of all the patients that are in the system across 3 dimensions of risk. The first dimension is self-assessment, and symptoms of the patient are in a diary, and what we're looking for is change from normal for the individual, not for groups. I think that's really important. The second dimension is what I'm probably best known for. My group published the first ever paper on early warning scores, and I was part of the team that launched the National Early Warning Score. So we got a good 20 years of experience of teasing out physiology in acute and chronic illnesses. And then the third dimension, that's really linked to the wearables. We're looking now at functional impact of disease by measuring movement and sleep. So we got 3 dimensions, how we can risk stratify using patient self-assessment, vital signs, and then the functional impact of that. I hope that answered the questions that you were looking for.
Great, thank you, Chris. You're now going to have a survey that's going to pop up on your screen. And what we're asking, if you would like to be put up in contact with either Pareto or SmartMed, then there will be a box to tick, and you can tick either one or both, and then we will be passing on your contact details for you if you want to explore a bit more about these remote monitoring, or if you want to find out a little bit more or ask some questions or find out where else they're being used. It doesn't mean that you're going to be buying the tech, but it's a way of us being able to connect people on the call. So I'm really pleased now. We just go on to the next slide, please, Laura. We've got Tara Donnelly, who's the Chief Digital Officer from NHSX, my former Chief Executive from the HIN. Really sad that they've taken her away, NHSX, permanently. But we're really pleased that we've got Tara talking about national perspective on remote monitoring for long-term and chronic conditions. So over to you, Tara.
Many thanks, Leslie. And I have to show you what arrived today, which is my HIN coffee cup, just to make sure I never forget you, as though I ever would. So I'm delighted to join this session today, talking about remote monitoring for long-term conditions, and tell you a little bit about what we've been doing at NHSX on this. And just many of you, I've had a look through the participants, and many of us have met in the past, but if we've not met, it just might be worth saying that my background is a long-term operational manager in the NHS, particularly in hospitals, which are fantastic places if you are acutely unwell, and they're not great if you're not, basically. So I've been really keen to use the power of digital to really change that dynamic for quite a long time. And it feels as though the awfulness of the pandemic has at least one silver lining, which is that people are suddenly having a new sense of how important remote monitoring can be. I was talking to a GP colleague recently who did a morning of video consults, and she said they all went really well, but there were two patients she would have liked to have come in, and she asked them would they come to the practice, and they both refused because they're worried about infection risk. Now, a year ago, if you'd surveyed patients, they would have said face-to-face is the gold standard. And suddenly there's been such a change that actually she was concerned that people are not presenting. And of course, we don't want digital to be the only way that people receive their care, but we definitely want it to be available as an option for many more people who would like to take it up. If we could kick off on the first slide, please. So just to go back to our experiences during the very first wave. So right at the beginning in March, NHSX was approached by a clinician who leads quite a big virtual ward out of Watford General Hospital about whether there was any technology that could help. He was using Excel spreadsheets and telephone calls, and he was keen to see if there was some tech that could help him. And we were able to partner him with an offer. We received lots of offers during, particularly during the first wave. And we had an offer from a tech company who wanted to help in a pro bono capacity across London and the home counties. So we very rapidly, within 4 weeks, it was between the approach and the first patient benefiting from this, we were able to set up a service that helps identify patients who are deteriorating. They have a pulse oximeter and use an app to record their symptoms, having been discharged early from hospital. And we were seeking to enable clinicians to react faster, improve the patient experience by having much more care at home, and ideally see if we could save some clinical time. And that service is now across 10 sites across London and the home counties. Next slide, please. It's a tool that's also being used as part of the German COVID response. We're just about to publish our evaluation that was done by KSS AHSN. Very positive results, particularly on the patient side. So very strong patient reassurance, a feeling that it was really quite life-changing to be able to look after yourself at home. Really liked things like the double tick that you see when you know that a clinician's looked at your results. And what clinicians particularly liked was the better stratification. So people who were recovering well, they didn't need phoning all the time, whereas those whose blood oxygen levels looked concerning could be brought straight in. So it saved particularly large amounts of time in the secondary care site. It equated to a full-time respiratory physician a week. So we're now doing active work to scale this to around 50 sites by the end of this calendar year, in a few weeks' time. And in a nice little bit of poetic twist, Matthew Knight, who approached us in the first place, was recognised in the Queen's Birthday Honours with an MBE for his work in the COVID response. But it nicely illustrates for us the power of of remote monitoring for acute conditions. Next slide, please. And then since then, or from July of this year, we started to do some work to really look at scaling. I lead a small team within NHSX, and scaling the most evidence digital innovations is our focus. And we are taking as our topic, and I think this will probably be a multi-year programme, looking at how you scale remote monitoring across the country. And we ran quite an open call with the 7 regional teams, and they were able to select priorities that chimed with the particular needs in their geographies, and in many cases scale things that they had tested during COVID and they wanted to expand. So they were able to look at people with long-term conditions, those living in care homes, and acute monitoring for those with COVID. They pitched to us for funding to support implementation efforts. So we know that often it's not the tech that's the tricky bit, it's the change management locally and building the technology into new pathways of care. And we were delighted to be able to support all the schemes, and they kicked off in September for quite an intense 7-month period. We've written about it, there's a number of blogs, and I'll put references to them right at the end. And I should say I will be delighted to answer questions, so if you want to put them in the chat, feel free, and I'll cover as many as I can. And we also looked at how you can make procuring these solutions a little bit more simple, as well as some support for adopters. And on the next slides, I'll just take you through some of those in a bit more detail. So we see it as a bit of a jigsaw. So the regional scale plans, that's the work I've been talking to you about around support for implementation, with many regions choosing to use their local AHSN for support. The simplifying access to solutions, we ran with the support of the Crown Commercial Service procurement exercise to make it a bit more simple for the NHS to select tools. And across the regions they're now going about selecting the best tool for them. Lots more information about this on the NHSX website. There's a bit of a microsite under the procurement framework Spark. Plus, we were really fortunate. We were able to obtain some funding for licenses as part of a COVID-19 bid. So many of the sites that are scaling remote monitoring for this year, at least, are not needing to put their own resource into it. And we're finding that is helping speed things up as well. And a really important aspect of the jigsaw is what we're calling the innovation collaboratives, which are the support mechanisms for those groups of adopters. So there's a community of adopters, there's an online collaboration forum where information and nitty-gritty stuff is shared, whether that's data sharing agreements or standard operating policies, lots of films. There's a series of webinars, including with people like Matthew Knight, talking about his experience, and counterparts in primary care who've run that service out of primary care hot hubs, really speaking to colleagues with the information that they would if they were just trying to let them know how to do it as quickly as they've been able to. Because all of the necessary steps were taken, and scrutiny and governance, they were just done at great speed, in particular the speed of decision making. And we've also finalised an AHSN network commission to support and accelerate this with a programme of events and podcasts and so on, being led by Health Innovation Manchester. And there are a number of things that are also linked. As part of work that we call Joining Up Care at NHSX, which is about health and social care coming together, we've bought 11,000 SIM-enabled iPads for care homes. This is enabling them to immediately make the most of multidisciplinary ward rounds for care homes that are being led through primary care, through video consults, and it will also enable them to share demographic details through the Summary Care Record app. So this is really a very important part of what we're doing. I believe over 5,000 iPads have gone out, with the rest going out before Christmas. On the outpatient side, we've been working with the Royal Colleges and the National Clinical Directors to say what would a really optimum digital outpatient pathway. And last week we published the first 5 digital playbooks, which are on cardiology, respiratory, ophthalmology, dermatology and MSK. Do have a look. They bring together all the best practice and the good examples of what people have been doing, including contact points to help people who would like to adopt more swiftly. And then final 2 points, we're very linked to the NHS at Home scheme, and in particular helping them scale up their hypertension offer, so blood pressure monitoring devices to the highest risk communities, and a platform to enable them to share those answers with their GPs, those results. And then the final step is evaluation. It's a new approach. It's a different way to run a national programme. It's much more decentralised and based on regions. So we're going to be doing that learning with support of an evaluation specialist partner. Next slide, please. And just a couple of examples of the types of things we mean when we're talking about supporting people at home. So this gentleman is Derek Jones. He has been on warfarin for a long time. And what people who are on warfarin need to do is very regularly come to hospital to an anticoagulation clinic to get their INR levels checked and their medication changed accordingly. He doesn't need to do that. He does it entirely from his own home, does a small blood test and texts his results to his clinicians, who can change his medication accordingly. He absolutely loves it. He says it's great. I do it in the comfort of my own home. And we spoke to him recently, and he said now more than ever, the ability to use this fantastic automated system is of huge benefit to me and my family. Highly recommended by patients. 100% of patients would recommend, so that's a fabulous net promoter score. And it gets really interesting when we look at the clinical outcomes. So people who use this service do better than those who do a traditional means of monitoring. They spend longer in the therapeutic range. So that's reducing their chance of a cardiac event or a stroke or early dementia. And this improvement was found to be long lasting. So it's a really nice example, because without this fund, it's been in one hospital in Durham, and they're using our resource to scale it to all of the hospitals across the northeast of England, with 1,000 patients to benefit by the end of March. Next slide, please. We were really delighted that all 7 regions chose to do some work in care homes. So that's been a stronger response than we were expecting. And the work in the west of England and the southwest is particularly strong in that area. And it also considers people with learning disabilities, who we know have been disproportionately impacted by COVID, looking to increase the proportion of people who have an annual health check by 50% using digital means. So it's a really very interesting piece of work to see if that can be spotted, because what we know is that people with learning disabilities do typically, it's a bit like people with mental health issues more generally, die much earlier than the rest of the population, and often it's the comorbidities that are the problem. So we're looking with a lot of interest at this and seeing if that's something that we could potentially scale to a larger extent subsequently. But again, looking at things like reducing the number of non-elective admissions to hospital. And we had a very compelling care home nurse talk to us at the pitch, who said she spends a quarter of every shift on the phone. She's getting information, particularly drug-related information, and that when she moved to a digital platform, it was transformational in terms of how much more time she could spend with residents. Next slide, please. So just a quick glance at kind of the nature of some of the projects. And if we go to the next slide, it starts pulling out what some of those impacts are planned to be. So we're aiming to reach over 100,000 people by the end of March, and in these sorts of ways. So in the east of England, looking at reducing emergency admissions from care homes by 17%. In London, some work to increase vital sign monitoring across care homes through a number of SDPs. And then the South East is doing a very large piece of scale work on the COVID oximetry at home model, impacting 13 CCGs using the same tool. So they're going up to a population of 1.1 million there. Next slide, please. I touched on the innovation collaboratives already, but just to say that we are really seeking to kind of apply improvement science to this. Sometimes we see the kind of digital people over here and the improvement experts over here, and this very much is a sweet spot for the two, because it's all about pathway change that happens to be supported by digital. So a number of resources available to people across the NHS and social care. Next slide, please. So this is my last one, but just with some a bit more info on some of the things that we talked about and some of the blogs that that I've mentioned. The very first one that we did on the 10th of August showcased a really lovely film based on a rheumatology remote monitoring service out of a number of trusts in Southeast London. It's a really good watch. It's very short. But what it does really well, I think, is it shows that when it's done well, remote monitoring can make people feel an awful lot more cared for, not less cared for. And there's a patient in that video who says that when she's well, she doesn't want to be reminded of her condition all the time. But when she needs assistance, she'd like to be able to get that really quickly. And they are, you know, that's the power of digital, isn't it? That we're able to personalise care much more. So I'm going to stop there just to allow some time for questions. I'm very happy to cover anything that people would find useful. Thank you.
Thanks, Tara. And a really big thanks, because I understand you're on annual leave this week. So you're doing this while you're on annual leave. So we will do the questions for Tara and then let her go and enjoy her time off. There's one question that's come up, Tara, that's around, it's quite a long question. So are there models of remote monitoring being trialled which integrate the measurement of patient data at home with digital behaviour change interventions, which facilitate self-management? So is there something around being able to, the remote monitoring, be able to facilitate self-management? Have you come across any initiatives happening?
Yes, definitely. And I think, I mean, using that warfarin example, that's very likely to be what's going on there, is that by people being actively involved, looking at their own results, that they're more likely to be an activated patient and therefore stay within range. So we are seeing a good bit about that. I would say there are several steps to get to nirvana. So lots of regions are having to use systems that aren't fully interoperating yet. It will be a journey to get that to where it should be. It will be really good, you know, looking at things like the rate of smartphone use. To have people using consumer devices to input data and share that with clinical teams. But absolutely, a big part of this is the patient empowerment aspect. We know people with long-term conditions spend many more hours a year looking after themselves than they are with a clinician. If we can help use that time as constructively as possible, that's great. One of the things that has bothered me for a long time is, in the NHS, long-term condition management basically is the bread and butter of the work of the NHS. It's at least 70% of time and resources, but unfortunately a lot of that is in the complications of disease. If we can only get to people a bit earlier and give them the support where they need it, we may obviate that conditions later down the line, which I think would be terrific. Oh, Leslie, you're muted.
I am going to do it eventually. Can I just ask, the Innovation Collaboratives, is that through Future NHS? Is that the platform that's being used?
So the platform that's being used for staff in the NHS and social care is Future NHS, the one that is typically used for this sort of thing. And that's where documents are posted and sort of messages are shared. But there are also a whole series of webinars that are open more broadly to people that will be advertising.
And there's one more question. So are there providers that offer smart home technologies and ambient sensor monitoring technologies for patients with multimorbidity in Northwest London? Have you come across anything? I know Northwest London do quite a lot around tech, but is there anything specifically around that?
I mean, I'm aware of some really nice examples of it, but not particularly within this scheme. As I say, we'd love this to be kind of a springboard, if you like, kind of 7 months quite intensive work towards really making sure that all of the major long-term conditions have a digital component, and that will take some doing, and it'll take some finding some resources and, you know, building up a bit of a coalition of the willing, but that's where we'd like this to be, not a sort of short-term piece of work that everyone thinks, oh, that was kind of interesting, but actually a bit of a sea change.
And I think going back to that question as well, we ran a social care event, digital social care event, with lots of sensor monitoring companies that have offered a solution for social care teams. So we can send that link out as well. It was all recorded, and there's some information there. And also on the self-management, we also ran a similar webinar to this for self-management digital tools, which we could send out as well to participants. I think I have one more question. So I suppose this is from a national policy. I'm just checking this question. Is oh, it's gone. The question was around: is there a plan that if someone's being remotely monitored for a long-term condition, is it that it's forever, or is it that it's a remote monitoring for a certain period of time? What's the sort of national policy on that?
So there isn't national policy, and there are some nice examples of both, to be honest. So there's been some great work in Sunderland where they are, after people have heart attacks, they are giving them a device if they haven't got one, and they run their rehab program through a device that's on loan for, I think it's about 8 weeks, something like that. So I think there are opportunities to use technology in a kind of short-term capacity. I mean, the COVID stuff would sit in that category. You know, most people they use the tool for 14 days and then that's it. But most of the regional scale plan work for people with long-term conditions is changing a pathway for good, and really having a different way of delivering care and stratifying outpatient appointments and so on. So there's a bit of a mix.
Thank you, Tara. I think that's all the questions that were asked. So thank you very much for your time, and hopefully you'll enjoy the rest of the day not working. Thank you very much.
Good to see everyone. Bye.
Now got 3 companies who are going to be giving their 3-minute pitch with the same question as before. We've got FibriCheck in healthcare and Patient Empower. So I'm going to pass over to FibriCheck to kick off.
Hi everyone, can you hear me all right?
You're good, yes.
Okay, perfect. Hello, my name is Felicia and I'm here on behalf of FibriCheck. With proven equivalence to single lead ECG, FibriCheck is a hardware-free digital application that transforms smartwatches and phones into a certified medical device for remote monitoring and detection of cardiac arrhythmias, enabling virtual stroke prevention for over 450,000 people, 75,000 here in the UK since March, simply by placing your finger on your smartphone camera. Atrial fibrillation, or AF, goes undetected due to its intermittent nature and late symptom onset, causing 20% of strokes. Early intervention can prevent 75% of these strokes, offering valuable in-year savings. But due to cost and hardware scarcity, access to remote monitoring devices is limited for many, resulting in unnecessary office visits and A&E admissions of society's most vulnerable and economically disadvantaged. By screening over 65,000 people in a week with just a code in the newspaper, AF detection tripled with multiple spot checks, proving FibriCheck's trailblazing application in long-term condition management. And population health scalability, meeting hard-to-reach patients where they are. For over 2,000 patients in primary and secondary care, FibriCheck's selectable monitoring duration, weeks, months, years, is integral to AF progression management, alerting in the early stages when intervention is less costly. Longitudinal insights between consults means no blind spots, efficient treatment, and improved prevention. Our real-time analytics brings together biometric and PROMS data, further enhanced by manual review by our medical experts, affording providers confidence in the findings. By annotating symptoms correlated to activity and completing a CVD risk profile, patients are engaged partners in care, improving condition awareness and therapy adherence. These elements come together in our diagnostic grade reporting and provider dashboard, supporting risk stratification for intelligent resource allocation and evidence-informed decision-making for better outcomes. For over 200 centers providing an on-demand virtual tool that empowers patients to self-manage, it's as simple as sending an email with a code, safely enabling quality care and care continuity at home. Our telecheck approach had centers up and running in less than a day, virtually onboarding 38 centers in less than 2 months at the start of COVID. By replacing 95% of in-person consults with FibriCheck monitoring, centers like Bart's in Liverpool track symptoms, intermittent episodes and relapses, procedure outcomes, and manage medication, all without the patient having to come in, increasing service capacity and reducing waitlists and backlogs for costly diagnostics, ultimately optimizing the AF pathway. 3 minutes is of course not a lot of time, so happy to take your questions. Thank you.
Thank you. And we will have an opportunity afterwards for question and answers for the companies. So please do put them in the Q&A box. So next, can I pass over to In Healthcare to start their pitch, please?
Yes, thank you very much. Good morning. In Healthcare is the UK's leading remote patient monitoring platform. We're established in 2012, and we now support over 600,000 patients a year to digitally engage with their healthcare professionals. The In-Healthcare platform is unique as we can rapidly build, deploy and iterate remote monitoring pathways for almost any long-term condition. Our platform has been used to build over 200 different pathways to date, including the INR warfarin service I mentioned earlier and the telehealth service in Hull for their COPD and heart failure. This enables patients to take their own blood pressure and oxygen readings at home and relay them to the In-Healthcare platform via a communication channel of their choice. They can use our In-Healthcare app, but they could also respond by SMS message or automated phone call. These readings are then automatically triaged by our platform against thresholds which are set for the entire cohort of patients, but adjusted for individuals if necessary. If a submitted reading breaches a threshold, clinicians can be notified that the patient might need some clinical intervention. All these readings are then integrated with the GP's clinical record via the In-Healthcare APIs with EMIS and System 1. The service in Hull included a 3-month educational program, which was also delivered digitally by our platform to enable people with long-term conditions to become more independent and recognise their symptoms by enhancing their knowledge of their condition, avoiding hospital admission and improving the quality of life. As you would expect, a lot of the work we're doing at the moment with trusts and CCGs across the UK is around COVID-19, in particular the COVID optometry at home and COVID-19 virtual wards. Patients are referred onto our pathway directly from within the clinical record system, where the monitoring frequency and oxygen saturation threshold can be set. Patients automatically receive a notification to activate the service and choose the communication method they want to relay readings back via. Patients then receive their pulse oximeter in the post and are prompted by a phone call, SMS or app notification whenever they need to submit a reading. All readings are then fed back into the In-Healthcare dashboard, where clinicians can see their entire caseload in one place, and the latest readings are displayed using a red, amber, green rating system, depending on how they sit against a predefined threshold. From this dashboard, clinicians can prioritise which patients need further investigation and arrange a video call through our platform there and then if required. Because all these readings can be pushed back into the GP clinical record with the associated CT code, it's easy for CCGs and trusts to report on the health status of one of our virtual wards from a population health perspective as well. As I mentioned at the beginning, the In-Healthcare platform is flexible and powerful enough to provide remote patient monitoring pathway for almost any long-term condition. And by providing patients with a wide choice of communication methods, we ensure nobody is left out by not being able to use their latest apps or smartphone technology. In addition, our ability to push data back into the patient's clinical record and the reporting element which opens up does make us truly unique. I'd welcome the chance to discuss any projects that you may be working on where you think we can add value after this session. And thank you all very much for your time. Merry Christmas, and very hopefully we'll have a better 2021. Thank you very much.
Thanks, John. And can I ask Patient Empower, please, to come on?
Hi, I'm Eamon Costello, CEO of Patient Empower. Ever before COVID-19, chronic lung disease patients have had the same time-based schedules. For many patients who are stable and have no symptoms, these appointments are unnecessary and could have been allocated to a patient more in need. Patients who need an appointment before their next scheduled one typically don't realise until it's too late and end up presenting at the emergency department. They're one of 700,000 lung disease admissions annually in the UK, responsible for 6 million bed nights. It's estimated up to 70% of these could be prevented with early warning and intervention. Patient Empower's platform allows chronic lung disease patients to be managed at home, providing objective early warning insights to prevent many of these unplanned admissions. It's a CE-marked software medical device which has 3 main components: apps customized to patient-specific lung condition and their comorbidities, an analytics engine to risk stratify, triage and alert decline in patients' lung condition, and a clinical dashboard to view the data with integrations into NHS systems such as the Care Information Exchange in North West London. The patient apps collect a range of data types, including objective data from connected devices such as home spirometry and oximetry, subjective data such as patient-reported outcome measures and activation measures, and geodata like how air quality can affect your asthma. The most important data for remote monitoring most lung disease patients comes from this device called a spirometer. The data it produces is entirely dependent on how hard a patient blows into it. In the hospital setting, this wasn't an issue, as they were supervised by a pulmonary physiologist. For home measurement, we have built a range of quality checks into our solution and conducted several clinical validation studies, allowing clinicians to have confidence in the data and, crucially, have confidence in the alerts and escalations from the home monitoring. We have a range of deployments live or planned across a number of NHS trusts, including Manchester, Birmingham, Papworth, and Imperial. These are providing continuity of care to lung transplant and cystic fibrosis patients, will escalate poorly controlled asthmatics from primary care into a virtual ward, and redesign outpatient care in pulmonary fibrosis, moving from time to need-based. This approach can save around 67% of outpatient appointments, as we've demonstrated with deployment with a large hospital system in New York. There can be some concern removing these standard time-based schedules, but our studies have demonstrated the contrary. Patients feel more reassured when they have more regular objective data to understand their disease and take comfort that their clinical team check in with them virtually, as Tara mentioned earlier. If you are looking to transform your respiratory outpatient care or would like to learn about our experience monitoring nearly 2,000 COVID-19 patients' oximetry at home, I'd love to hear from you. Thank you.
That's great. Thank you. Thank you, everyone. We're now going to have the survey up again for these three companies. So Kate, can I just ask you to pop up? So if you tick which company you would like to be able to hear more about, as I say, it's just being able to pass on your contact details to be able for the company to be able to talk through their product. We'll also be circulating with the presentations all the contact details of all the 5 companies as well, so that if you want to go away and think about it, you can always contact them after the event. That's great. And then remember, there's an opportunity after we've heard from the last presenters to be able to ask questions. So please do put them in the Q&A box that's at the bottom of the screen. So I'm now going to pass over, I think, Oliver, you're kicking off first.
Yeah, that's right. It'll be a joint effort between me, Neil, and Chris, I think.
Fabulous. The trio, the wonderful trio, hey.
Yeah, thanks very much, Leslie. So we're going to talk to you today about kind of what we've learned this year, trying to do diabetes annual reviews remotely. This is linked to UN Type 2, which is a project that we've worked on for a couple of years now. So I'll just ask Chris and Neil to introduce themselves first, and then I'll give you a bit of background on the project to start.
Hi, my name is Neil Basdev. I'm a GP in Lambeth and work as the Clinical Director for Diabetes at the Health Innovation Network.
And I'm Chris Gumbel. I'm a Project Manager at the Southwest London Health and Care Partnership, working on a range of projects, including this.
Great. So I actually didn't introduce myself, did I? So sorry, I'm Oliver Brady. I'm the Programme Director for Diabetes at the Health Innovation Network. And previously I worked in Southwest London when we started this project. So Laura, if you could just put on the next slide, please. So UN Type 2 is a project, as I said, we've been working on for a couple of years. It's a partnership between Southwest London CCG and the HIN with several digital innovator companies. And it's a project that was funded under the NHS testbed programme, where we had the aim of trying to make it easier for people living with type 2 diabetes to access the support they need, and particularly to get really high quality care planning. So we've developed a pathway that brings together some of the sort of best practice care and support planning pathway that has been tried and tested around the country by Year of Care partnerships, and it sort of enhances that with the introduction of digital tools that can help us make sure that the patient has the information they need at the right time and is supported throughout the year. So we started this a couple of years ago, and obviously, as with most other things that people have been working on in healthcare this year, it's been disrupted by COVID, and we've had to sort of pivot in a new direction. And that's really what's led us down this path of looking at a fully remote version. There was already a strong digital element to the pathway, which I'll talk you through in a minute. But I think we'll start with Neil giving a bit of a background of kind of why we were trying to do what we're trying to do and the challenges that we were trying to address with the original project. And then we'll talk a bit about the what we've learned this year with the remote pathway.
Thanks, Oliver. We go next slide, please. So this, I guess, lists some of the issues that we found were happening, and you can break them down into problems that were happening at a patient level, practice level, and in terms of the technology. So in terms of care and support planning for patients, for example, there's definitely a lack of information for people outside of that appointment window. You know, as kind of Tara alluded to, most people will have very limited time with a healthcare professional. And in terms of self-management, then they're spending all of their time trying to manage a long-term condition themselves. And the time that they've got with, you know, say myself as a GP would be very limited. There's often a lot of information that's flowing within that appointment. And the ability for me to offer people support outside of that appointment window, again, is very, very little. At a practice level, various practices work in different ways. Some have robust systems for calling and recalling, most probably do not. So you're relying on opportunistic care, which can mean it's disorganized, therefore. There are also then time constraints. So if you're trying to do as much as you can within your 20-minute appointment window with someone, you're trying to do a lot of care and support planning work, but unfortunately that's often overshadowed by tick boxing, foot checks, BP checks, etc. So there's a bombardment of information happening. And the technology or was sort of non-existent, and so therefore if people were making care and support plans, those plans are invariably on bits of paper get lost, bits of paper can't be adapted, bits of paper are not shared with other clinicians, and therefore it makes the actual care and support plan that people are making not as useful as it should be. So these plans are not adaptive, they're not dynamic, they can't be changed. And these are some of the issues that we identified from the get-go and tried to sort of improve with this project. Next slide, please. So we can think of care and support planning as a kind of wheel. If you look at the wheel on the left, it's made up of various components, and the component that was kind of happening before this project was the education bit, but even that was not happening as much as it should do. And so we've tried to light up in effect the entire wheel, and we've tried to improve not just education, but also communication with people, they're accessing support services, the data that they're holding, and the actual care planning element itself. And you can see some of the innovators that we've worked with. So they're listed there. And I think the most impressive thing for me about this project is that we've worked with multiple innovators. They all do something a bit different, but they all work synergistically and well together. And we need all of them in order to make care and support planning happen. Next slide, please. I think that's maybe for Chris or Ollie.
I think this one's me, actually. So just to sort of walk you through the pathway to give you an idea of what it is before COVID and how we've changed it. So it fits around the annual review that a patient would normally have. So it's routine care. And the first step is about gathering that information, those test and checks, ticking those boxes that Neil mentioned. And this is deliberately separated in the year of care pathway from the care and support planning part of the consultation. So you have 2 appointments, and it's separated so that you can really focus on having a quality personalized conversation in the second call, as it will be now. And the first bit, which is about gathering the tests and checks, is normally done by a healthcare assistant or a nurse in practice. And previous to COVID, we were doing that as a face-to-face appointment that would last 15 or 20 minutes with an HCA. Then following COVID, this is the part that we've turned into a remote pathway. So instead of coming in to have those tests and checks done in person, the patient will complete some tests and checks at home, including blood and urine tests. And a couple of the partners that we're working with are shown there. We'll talk a bit more about them in a minute. And that is now followed up with a phone call from a healthcare assistant to ensure that the person, to ensure that the practice has all the information that they need. The next step in both our pathways is that the patient then gets those results shared back with them. And this is really important in terms of getting someone prepared for that conversation that they're going to have with their healthcare professional. Particularly important, I think, when it comes to remote monitoring. One of the things that we found is some patients are quite reluctant to move away from the model of care that they're familiar with, and having a way of conveying complex information in a meaningful and engaging way to patients is really important, I think, more so now than ever. And so I'm just going to give you a quick play of an example of one of the videos, which we won't play all the way through, but give you a taste of what it's about. And obviously this is a dummy patient that we've created, not real patient data, but all of the numbers and names you'll see in the video are actually drawn from an EMIS record. So if you can just play that, Laura, for about a minute or so.
Hi, Angela. Thank you for coming to see us recently for your annual type 2 diabetes checkup. When we met, we talked about the U and Type 2 service and about how it might help with the things that matter most to you and help you to live a little more easily with type 2 diabetes. At your next appointment, together, we will plan the help and support you want so that you can deal with the things that most concern you. To make the most of this next appointment, we'd like you to take some time to think about what it is that matters most to you and what you want to achieve in this coming year. The tests we completed last time have been analysed, and we can now share the results with you. Traffic lights appear alongside each result to help you understand the risk of complications associated with the result. A red light indicates higher levels of risk, and green, lower levels of risk. HbA1c shows the average level of glucose in your blood over the last 8 to 12 weeks and is a way of showing the risk of you developing future complications. Generally, the lower the number, the less chance there is that problems or complications linked to type 2 diabetes may develop over time. A level of between 48 and 58 is associated with the lowest risk of complications. High blood pressure is...
So that gives you a sense of what the video's like, and it goes through all of the different results that we collect for a patient, and we've had really great feedback on those. So really important, I think, advance we've made with this, testing this at scale. And it's important to know that that technology could be used for any condition. It's very much sort of agnostic to the condition. So once the patient had their results back, then they don't come in anymore, that they have a follow-up consultation, and this will now be done as obviously as a lot of care is being done now with video consultations or on the phone. We have developed some software that sits within EMIS that, if you can just move us on, Laura, we'll show you a quick sort of snapshot of what it looks like. But essentially, it's just a structured way that people can collect the information from a care and support planning appointment. And if you just flip to the next image, Laura, it will show you the sort of thing that a GP or nurse would see when they were filling this out. It has structured goals and content in there that can help quickly create a really personalized plan, which can then be either printed off for people who aren't sort of smartphone enabled, or if you can move us on, Laura, can be shared back to a patient's smartphone using a sort of companion smartphone app that we've developed with Helam. And that app really has the care plan in, the resources, access to local social prescribing resources, education courses, and so on. And if Laura clicked us on one more, we'll see just a kind of quick look at some of the screens within the app to see how that looks. So Chris is just going to quickly, I think, whip us through where we got to before COVID to give an idea of some of the impact we were having before this interruption, and then we'll focus on the remote pathway and what we've learned there.
Fantastic. So as you can see, 34 practices across 6 South London CCGs volunteered to take part in the project. Obviously, each with the ambition of improving patient care and streamlining pathways within their practice. We trained around 101 healthcare professionals in the year of care process and methodologies, and we had regular follow-ups and mentoring with those practices and their staff. We provided training for healthcare assistants and nurses to support annual foot check completion and improve referral pathways. We also hosted training for admin and other practice staff too. So we had quite an embedded approach within the surgeries. Some practices also provided their own staff with training and with some success stories where admin members were becoming HCA. So it was quite a great outcome for us to see those individual things happening. So as you can see, there were over 3,000 initial information test and check appointments to collect the key care process data, and over 2,000 care plans were created. So within those care and support planning appointments, over 300 patients were identified as needing the input from Aviva, which is a behavioural change weight loss kind of intervention. Early testing of the personalised video messages and of the video that you just have seen showed huge engagement data, with nearly 100% of the videos being opened, with a really, really high retention rate. So really successful first component, and then COVID happened. So we'll go on to the next slide.
So I guess what COVID happened, you know, we sort of started seeing that big impact in March, didn't we? You'll notice that on our timeline, it starts in May, because I think for the first couple of months, I'd been seconded to work on ITU planning. I think others have been busy with, I think Neil sort of sorting out his the chaos that gets created in primary care as well. And so we regrouped in May, where a couple of months where not a lot of chronic disease management had been happening in primary care with the practices that we were working with. And we had a chat, the three of us, about what we could do. And we sort of started thinking, can we do this entirely from the patient's home? And that led us to a process of kind of partnership building, sort of thinking, what is the art of the possible here? Looking into how we can develop those tests and checks remotely, which is the key part we needed to change. And Neil, in a moment, will talk about the clinical pathway that we developed, the sort of protocol that he developed, really, for us to be able to do that. But what we've done is we've had a couple of goes at this. So we did what I described as a quick and dirty pilot in August to see, kind of just generally speaking, how do the patients and the healthcare professionals involved react. We changed a few things, and we're just at the moment in our second iteration of that pathway. So we've made a few tweaks, and we're hoping that in the next month or so, we'll have kind of data from those first two cohorts. And if it's promising in terms of engagement and clinician feedback, then we may well extend it to a wider pilot in the new year. If you could just move us on, Laura. Thank you. So to reiterate, what we were trying to achieve with this remote pathway wasn't perfection. We weren't trying to find a way to ever remove the option of face-to-face care or replace it entirely. We never assumed that we would be able to do something that was offering the same experience at the same kind of cost, I suppose, as face-to-face care. But what we were saying is there a way that we can do this for some patients that is acceptable to patients? Not necessarily all patients, but certainly a cohort of patients that are prepared to do it. It has to be fully remote, so there's no interaction outside the patient's home necessary. That was another criteria we set at the start, and that it had to be able to give clinicians the information they need to undertake a proper care planning annual review with their patient. But they have to have the confidence in the results to make that worthwhile, and be able to indicate to clinicians where you know, these are the patients that we maybe do need to bring in and see face to face to get the more detailed investigations done. So there's a risk stratifying element to it as well. It's not just about replacing face-to-face care. It's about identifying which patients need face-to-face care. And so as we mentioned earlier, we've partnered up with a few different people to do that. I can't remember, if you could just flip us to the next slide, Laura. I think this is Neil's going to talk about the protocol and the partners that we're working with.
Yeah, thanks. I guess the first thing to say is that there are, as you can see from the table, there's a lot of data to capture as part of a diabetes review. So we talk about 8/9 care processes. The bit on mental health there is a kind of add-on, but all the ones above mental health are what should be captured sort of on an annual basis for people. So there's a lot there to try and get remotely. And these are people who may not have been seen for a while, and obviously we're all working very new ways. So it was logistically quite complex. So, and as Ollie alluded to, we try to be as pragmatic as possible and say that some bits of this data we will get, many bits we won't. If we can't get data, how can we mitigate that? What could we use from patient records? Who do we then need to sort of think about seeing face to face? So there was some stratification element to this to help guide practices and say, you know, because this patient, we want to, for example, getting blood pressure is a good one to start with. Some people have a blood pressure machine, most people don't. If they don't, we gave suggestions, for example, on blood pressure machines that they could purchase for, which are relatively inexpensive. And we gave them support via a website we created with advice and so forth to signpost them to, here are blood pressure machines you can get, here's how to use them, etc. And therefore we could capture data that way. If they couldn't get a blood pressure machine, we'd then maybe have a sort of pragmatic way of looking at that and saying, this patient's previous blood pressures were all fine, therefore the chances that it has gone up are low, and so you may want to defer seeing us face to face, versus someone who's previously had very high blood pressures, and therefore the chances that it still remains high are also high, so you may want to therefore be seeing them. So that's the sort of way that we took things and tried to, you know, work as best we can in a very new and different way. We then tried to get some of the blood tests done remotely, which is using a company called Thriver to get their mainly their HbA1c, cholesterol, and EGFR, which is a measure of renal function. So that worked with Healthy.io, which is the other company, in terms of getting a albumin creatinine ratio, which is part of their kidney checks. So those were all done remotely, and people would be sent out test kits to capture that data and send it back, and that data would then be we would then input that into EMIS, and some of it is automatically inputted, some we'd have to manually input, so that we could try and get as much of this data before discussing it with the patient. So we tried to keep to our original ethos around care and support planning, and not be too sidetracked from that, because the whole premise of how this works is very important, that we capture data, we give that data back to the patient in a meaningful way that they can then understand, because that conversation between myself and the patient, for that to happen properly, the patient needs that information, and they need to see it and understand it to allow that conversation to be more meaningful. So that whole ethos was still underpinning all of this. The foot checks is the one that probably asks, you know, has the most kind of feedback from people. How do you do a foot check remotely? Again, very difficult. There is you know, conflicting opinions on that. I think generally most people would say that it probably can't be done ideally remotely. So again, you have to be fairly pragmatic here. We used scripted questionnaires that the healthcare assistants could run through, for example, to help triage people who therefore might have foot problems happening, and therefore might benefit from more of a face-to-face appointment versus being done remotely. So again, the whole premise around this was trying to get as much data as we could remotely, and where we couldn't, then we were taking a very pragmatic approach and using existing data, or deferring things till later, or asking someone to come in. Next slide, I think that's for you, Chris.
Cool. So I'm going to go through some of the findings from, as Ollie calls it, the quick and dirty phase 1 of the pilot we conducted in August. So there were 3 different surgeries offered to take part in this remote pathway pilot, and there were a selected number of patients offered the opportunity to be involved. So as you can see, we had around a 34% uptake rate, which, to be honest, was probably better than we had predicted. So, and that was only phase 1 in the raw state. So there was variability in the cohort that were offered the pathway. So some of those offered or identified using a risk strat tool as being high risk of COVID. Others, it was where it was just their time to have an annual review that was due that month. And with one practice focusing purely on the patients that were listed and required to shield. So more patients out of that cohort were willing to complete the home urine tests. It was found to be really an easy process to undertake. But the really good thing for us is there were 9 cases of high abnormal results discovered, which prompted follow-up and further investigation from the surgery. It was a more difficult task to convince patients to complete blood tests at home. but we still managed to get some completed, and there are still a few pending results. But in phase 2, this has significantly increased, which we'll share at a later date. So next slide, please. So I just wanted to give you some of the key findings and challenges. So our most successful cohort that we've worked on from phase 1 were our shielding cohort. Kind of the best recruitment method that we had was whereby surgeries were sending text messages to patients, following up with phone calls, giving the hard sell, because it's a really difficult thing to convince somebody whereby you're used to having everything done for you, coming to a surgery, you follow a pattern, and this is a brand new thing. The main issue that we had actually was the complexity of the pilot pathway and the lack of integration. So what we envisioned this being in phase 2, 3, 4, whatever it may be, is a one box, one phone call, one pathway. But at the moment, we're just trying to get everything integrated. And the easiest win definitely was the ACR. Very successful, easy to use. Patients really found it useful. The hardest challenge was actually convincing somebody to do a blood test at home. And it's in a different method than their normal route. There was a slight lack of human support in some of the components where things were quite manual, and you had to use the internet quite a lot, and you had to sign up for accounts and this kind of thing. But we've already started to adapt that in the second phase, and it's not suitable for everyone. People that have needle phobia, for instance, or those that don't have access to technology, maybe even those that speak English is not their first language. So we've got identified challenges that changes that we're doing. So we're improving the training around how we sell this pathway within the surgeries. We've already adopted a slicker referral system to our remote partners, and we're embedding more of a human contact. So as Oliver said, this will never be a replacement of the face-to-face, but the more that we can join these things together, the more we can connect the dots. Hopefully, the people that it will benefit will get best use out of that process. And that's me, and I think we're done.
Thank you. I think that's fascinating, and it's so, I know we've been talking about diabetes and how to use some of the at-home testing, and it's in some ways COVID, as we know, has rapidly accelerated some of the innovation, but it's a shame it's taken a international pandemic to do that. But there's a couple of questions that we've got in the Q&A for you guys, and then there's some questions that we'll come to for the companies as well. So to the diabetes team, if you write something in the app to the patient as a clinician, will this go into EMIS? So does it transfer over to EMIS?
It's a very good question. So the way that our software works is that it can read out of EMIS, but it can't change the EMIS record. So if you want to create a record of your conversation with someone, you have to print that PDF record that you might give to a patient if you wanted them to take it away. If they didn't have a smartphone, you have to save that to the EMIS record. You can't change results within EMIS. Now you can use it though as a tool to communicate with patients. So you can write into the app, and so if you write something using the software that is connected to EMIS, it will appear in the patient's app. It won't change their permanent EMIS record, if you get what I mean.
I know you guys with the whole EMIS integration, it's been quite a long time and quite challenging.
Yeah, we could probably do.
If you've got any tips for sharing with anyone else around how to get the interoperability with some of the EPR systems?
Yeah, we're very happy to talk about that. We would be here all day though if we if we did it now.
Well, there's another question in relation to this. So can results be shared with other systems such as Vision?
So another great question. So in Southwest London and Southeast London, where we've been trialing this, the majority of practices use EMIS. There are some practices who use Vision, because we were on a time-limited project, we only did one integration for our software. So we only integrate with EMIS at the moment. But the ambition would be, once we've got good outcome data from our initial pilot, which we're expecting 12-month outcome data to be available from next year, we would be looking at a business case to scale it up. And at that point, we would obviously want to offer it to Vision practices as well, but that would require a next stage of integration that we haven't yet done.
Okay, and there's another question from Elena, which interesting that she was having a conversation in Waitrose with someone about their their eyes, retinal screening and reducing the pressure. So it's how do you manage I think you mentioned about foot care, but how do you manage eye care for diabetes patients?
So I might let Neil take this one.
So eye care is back and running, but the eye care system has changed slightly. So it's moved from annual reviews to 2 yearly for most people, unless they have existing eye problems, and then it will remain as sort of yearly or even more frequent follow-up. So the eye care as a kind of care process that's why I said it's sort of 8/9 care processes, because that's more of an automated thing that's done outside of primary care. It doesn't require the GP to initiate referrals or do anything, that the system sort of works very remotely. Our role is more of sort of data entry bit, so where you get a report coming back with showing eye disease or not, is coding that into the EMIS system.
And there's another question, I think you mentioned it, about is it right to encourage people to do blood tests at home if they don't want to? So how did you approach it with talking to patients to sort of encourage the blood test at home?
So Chris might be better to take this one.
Yeah, I mean, at no point was anybody forced, and this is a complete opt-in service. So those people that were offered the remote pathway, it was fully explained by the healthcare assistant or admin team about what was involved, what's expected, and it was purely an offer. So that's why we were quite excited by the 34% uptake, because let's be honest, who wants to do something at home when you're used to getting something done for you? But I think the surgeries did a really good job at creating a lovely balance between the necessity and the offer. And yeah, people had free choice, and if they weren't willing to do the remote pathway when needed, face-to-face was also offered as well.
That's great. And I've got one question actually. So with all of your digital interventions, there's always addressing the digital divide and making sure we don't create more health inequalities. So within your whole design of the program, how did you make sure that people weren't getting left behind because they didn't have the right digital devices?
Yeah, it's a really good question. I think actually it's a big challenge for us, because we were fitting around routine care, not sort of cherry picking people that we thought would benefit originally. Obviously, there's a slight element of a cherry picking in the remote pathway because it gets offered to everyone, but obviously there are certain people with this pathway that can't take it up because they don't have that digital access. But with our general U and type 2 pathway, obviously those tests and checks, if you can't get them done remotely, get done in person by your healthcare assistant. And the software is designed in a way that you can easily print out a very readable version of the care plan for someone who doesn't have any technology to take away with them in the sort of traditional way. And just to say that on the inclusivity side, we've also adapted and added a lot of content in other languages, and that's appropriate for different cultural groups within the app, so that people can get stuff that's relevant to them or in their language as well. There is a plan in the longer term for that video that you see, which gets delivered by text message, so you don't need to have the app, but you do need to have a smartphone to have that subtitled into different languages so that it can be understood well. But one of the bits of feedback we did get, interestingly, is that even people, I think this was from Neil's practice actually, people who receive the video that don't speak English very well were able to understand it because it is visual, and also share it with their family members and stuff. And they said like the whole family can understand what's going on. And it was really nice to receive that feedback, because that was something that we didn't necessarily plan, but it shows that it is a good resource.
Great. Well, thank you very much to Oliver, Neil and Chris. That was a really, and I'm looking forward to seeing this written up into a nice pilot report so that we can see and learn some of the lessons from what worked and what didn't. I think it's really useful to sort of talk about how you could quickly do something, but what the challenges are and what can be learned from it. So I'm just going to ask some of the companies, I mean, they're not directed directly at any particular company, but there's a sort of general question that was asked earlier about how much of an issue can patient adoption be of these solutions? Can installing apps be a barrier to adoption sometimes? I know that data usage, people are paying for data, that can also be a challenge. So any ideas on how to overcome that? So who wants to go first?
I'll kick off and maybe a few others chime in. I think it really starts with kind of user experience design and developing personas, understanding who the users are. So I think for some there has to be kind of a low tech version, and that can be kind of not as some of the previous speaker said, not app based, but still maybe needs some connectivity and as simple as SMS based. But I think you have to look at the specifics of particular patient populations and conditions, but it starts with really understanding the users, developing personas to understand all the different types of users you have, and then understanding their pathway and how you can help.
Yeah, I can support that. From my experience, certainly in the international market, where the tech knowledge wasn't that great, what we found is that you don't expect everyone to take this service up. You might have, say, 600 patients with diabetes or COPD in your practice. It doesn't mean that everybody would take this up straight away. So what you do is you identify the low-hanging fruits in a way and get them involved, and over time bring others along. And that's something that I think is very important here. Remote monitoring doesn't mean replacement of other channels that you engage with patients. It's one channel that you use across your practice or your clinic. It doesn't necessarily mean that everybody goes on that platform and that's it. And that's very important. Otherwise, you'll be disappointed. And certainly what Iman said about user experience and so on, it has to be very, very simple to use. The silver surfers are very used to pressing buttons. So Bluetooth connected devices and things like that, we find it very difficult because that's something that elderly people always have problems with, but they could type in a number. So you could give them a non-Bluetooth blood pressure device or pulse oximeter, and they could type in the result. That's quite doable. But anything more complex, you are entering something that is more difficult.
Yeah, I think I'd just like to add to that as well, that I think a lot of these digital tools, Sally said it right, it's not for every patient. There are some patients that this will not be suitable for. I think it's true that there won't be some clinicians that this won't be suitable for as well. Some of the clinicians that we train this out to, it's not for them. They even now they prefer the traditional phone call or bringing them in or going out and seeing them, and that's absolutely fine. I don't think our approach is never that we're enforcing this on people, but we are making the tool available for people who want to use it both clinical and patient level. One of the things we've learned in our experience is the digital element of it. We try and almost remove that altogether. We try not to make it a technological solution. This is a solution that's designed to make you feel better and keep you safer at home. And one of the ways that we do that is that we use natural language processing with things like Amazon Alexa. So if somebody's completely not comfortable with using apps or tablets or smartphones or whatever it is, at the very basic level, they can say, Helen Healthcare, my blood pressure reading today is 187, whatever it might be. And just by capturing that information in that way, we can integrate that into our platform, clinical records, and so on. So I think it's about making it as open as possible for patients to have that choice about how they would like to communicate with these services, and kind of removing the digital bit as the barrier.
Thank you. Chris?
Yeah, so just to add another aspect to this, I think adoption barriers is about trust. So to have a clinical team that's engaged and is able to establish this trusting relationship with patients, I think is a really important part of adoption. And one of the things that we're working on at the moment in the research sphere is that we're using peer support for patients, so friends or close family members, to support them through the process of adoptions. And we just published the first paper out on that, that you can look up online. But so that, I think, is probably a way to also improve compliance, reliability of processes and things like that.
Okay, and Felicia?
Yeah, so just picking up on that, what we have seen in practice is actually, we always talk about the digital divide, but actually a fair number of patients, especially older patients, are a lot more digital savvy than we give them credit for. And I think a lot of them, where they have their grandchildren or their kids involved in their care, or in their home environment, we do see a lot of support in that way. From our side, we both have a QR code, which you just kind of hover over the piece of paper that's given by your provider, either in practice or over an email, for example. But we also have a typed out code. So as they mentioned, sometimes it's easier to just enter in like 3 letters, and then that also activates it. So I think it's really about, at least when I look at our UX design, it's really about understanding who the demographic is, ours being primarily, the over 65 crowd, and catering that to how do they need to use it. So patient-informed design, I think, is a big thing. Our app is not the most elegant, but it's not meant to be, because it's meant for people to just simply push one button, take a measurement, and that's it. And I think there it really comes down to how do you make it super simple for people so that you do have the adoption and the uptake and the adherence that you're looking for.
And just one more question, data security, how do you make sure that patients' details are kept confidential? One person to answer, just aware of time.
I'm happy to cover from Aparito's point of view. We work with high, standards, ISO 27001 being the sort of international standards, but then obviously adhering to the UK Cyber Essential Plus and general consent and GDPR. So I think there's enough guidance and processes now that we should all be adopting to ensure that we maintain that.
One quick thing on that one, on the data, sorry, is that we don't actually keep any data on the phone, and it's double entry to access the app. So you have the phone security and you have the app security to access it. So all data is kept within the hospital environment or in a cloud environment that is fully approved by the hospital.
And just one thing as well, if anyone is looking at procuring any solutions, there's lots of different procurement frameworks that are out there where all the companies would have been through an information governance and security checks and make sure they meet all the regulations. So I think the assurance there is on procurement and how you procure the solutions. So just aware of time. So thank you very much to all our companies that pitched today. Very interesting, and we will be passing on their details. Laura, could you just share the screen for me, please? The last slide. So I want to just really close with a few tips that we've picked up with all technology about how to implement technology. And this particularly came out of a roundtable that we ran with some MSK providers recently around using, it would less so remote monitoring, but about tech in general. So co-design with staff, always really important, making sure you've got a period of time to walk through the tech and that you've got the tech company. And I think if we go back to the diabetes challenges that the project had there was around making sure that there is more human contact between the tech company and patients and clinicians. And when it comes to clinicians, making something as easy as possible to use. So not giving them a really complex way of being able to log in. I know London Ambulance Service use the thumbprints for iPads for the paramedics on the rigs. Rather than asking them to be able to log in. So they use their actual thumbprint. Making sure your alerts and escalation routes are built in. Making sure that you're choosing the right patient cohorts. So if we look at the diabetes example, it was about looking at which patient cohort would be more applicable to the remote monitoring side. We talked a little bit just then about information governance. So making sure the patient knows how long and where the data will be held. And also making sure that you keep the patients interested. There's lots of research out there around behavior insights and keeping people engaged, using things like gamification and goal setting. And then finally, making sure you've got continuous improvement and you've got a feedback loop with your patients. If it's not working, trying something else, using some of the quality improvement methodology around the PDSA cycle, seeing what works, testing it out. So we're now come to the close of the event. I just want to say thank you to all our presenters, really interesting. So thank you very much. Thank you for your time. I hope you found it useful. I found lots of tips and picked up lots of interesting information. And thank you for your time. Thank you.